Hello students, I am Dr. Barath from the Department of Oral and Maxillofacial Surgery, Vinayaka Mission Sankaracharya Dental College. Today we are going to see about mandibular fractures. The term fracture is defined as any breakage or any break in the continuity of the any bone. Okay? But today we are going to see the fractures of the mandibular bone. The contents of today's class are applied anatomy of mandible, etiology and incidence, classification, clinical examination, followed by that we will have imaging, management. Under management we have closed treatment, open treatment, geriatric mandibular fracture, pediatric mandibular fracture and post-operative care. And then comes the complications and recent advances. So applied anatomy. We all know that mandible is a jawbone which helps in mastication, speech and deglutition, and it develops from the first pharyngeal arch. At around 4th week of intrauterine life, it is derived from the Meckel's cartilage. And about 7th week, it gets ossified by the intramembranous ossification. And mandible has growth spot at the condyle. So the mandible grows vertically downwards and forwards with the growth spot at the condyle. And it gets its blood supply from the inferior alveolar artery, which is a branch of maxillary artery, which in turn it's a branch of external carotid artery. And it gets its nerve innervation from the inferior alveolar nerve, which is a branch of mandibular nerve and lingual nerve and long buccal nerve. So coming to the osteology of mandible. Mandible is like a horseshoe shaped bone, and it has symphysis region which is located between the two central incisor, and a parasymphysis region which is from the central incisor to the canine before the mental foramen. It's called parasymphysis region. The region after the mental foramen till the angle of the mandible is called body. The angle region, the area just distal to the third molar is called the angle of the mandible, and anything above the angle until the sigmoid notch is called ramus. And it has two horns, which is on the anterior side is the coronoid horn and the posterior one is the condylar horn. So here we can see the condyle and this is the coronoid process, and this is the line process along the outside of the mandible or outer surface of the mandible is called external oblique ridge. This is a bony elevation, and inside there is a elevation similar to the external oblique ridge. It's called the internal oblique ridge. These two oblique ridges joins at the anterior ramus area here, exactly here. This is the anterior ramus area. There it forms the coronoid notch. Since this coronoid notch is an important landmark in giving inferior alveolar nerve block. So you palpate the external oblique ridge and go along the anterior border of the ramus, and you get into a depression called that is the coronoid notch, that you keep it as a reference for your inferior alveolar nerve block. And there are other processes also, and in the center we have the genial tubercles, and it is a two pairs, that is one pair of genial tubercle, lower genial tubercle and superior genial tubercle, where genioglossus and genioiod muscles are attached. This genioglossus muscle is so important that it keeps the tooth protruded, not preventing it from falling back. So when the tongue falls back, this tongue will go and impede your airway, so thus thereby causing difficulty in airway. So this difficult airway leads to gasping and thereby leading to brain damage. So in cases of fractures of bilateral parasymphysis, this two segment will get fractured and pushed back due to the tongue fall back. So what happens in that case is this will put pressure on the airway so that there is gasping for air. And we have submandibular fossa exactly in this region, so where the submandibular gland is situated, and muscles are attached to the bony region for the effective mastication, speech and deglutition. And you can see this is the angle of the mandible where the vertical part of the mandible and the horizontal part meets. And there are three angles. One is clinical angle, surgical angle and anatomical angle. The anatomical angle is the posterior border of the mandible and the inferior border of the mandible joins. It forms the anatomical angle. The surgical angle is where the external oblique ridge arises from the anterior border of the ramus and the alveolar process of the mandible meets. The clinical angle is where you can see the internal oblique ridge from the anterior border of the ramus and the lingual aspect of the mandible, and it forms the origin of the internal oblique ridge. And it has mental tubercle, and it has a sigmoid notch, and on the medial side it has a lingula. Lingula is very important in orthognathic surgery because just above the lingula it's a mandibular foramen. This through the mandibular foramen only mandibular nerve enters and becomes an inferior alveolar nerve. And before entering into the mandibular foramen, the mandibular nerve gives a branch of lingual nerve which supplies the tongue, and here is the mylohyoid ridge where the mylohyoid muscle is attached. Okay, coming on to the muscle attachment and the associated structures, we know that on the lateral side of the mandible, that is the outer surface of the mandible, we have the masseter muscle, buccinator muscle which is attached here, and we have the platysma on the lower border, and slightly above the platysma we have the depressor anguli muscle, and above that where the external oblique ridge ends, just below the mental foramen we have the depressor labii inferioris, and coming to anterior, just the apex of the lateral and central incisor, we have the mentalis muscle which helps in the lip eversion and competency of lip, and we have a circular muscle which surrounds the oral orifice. It's the orbicularis oris muscle. And coming on to the inner surface and the internal aspect of the mandible, the coronoid process is attached to the temporalis muscle, which is very important, and the pterygoid fossa, which orbits the lateral pterygoid muscle, which attaches into the pterygoid fossa. And we have the medially the medial pterygoid muscle which is attached to the medial surface of the angle, and as I said, along the mylohyoid line attaches the mylohyoid muscle, and genial tubercle, we have superior genial tubercle gives attached to the genioglossus, and inferior genial tubercles give attachment to the genioid muscle. Now we know how the lingual nerve is going. It's going just below the alveolar process or the marginal ridge of the alveolar aspect, almost 0.8 centimeter or 8 mm from the alveolar ridge. So in case of elevating the flap or any fracture, most commonly lingual nerve getting severed is very common. And here we can see the maxillary artery along with the mandibular nerve, that is the inferior alveolar nerve, enters the mandibular foramen. And here you can see maxillary artery, which is a branch of external carotid artery, and just superficial to the superficial temporal artery, medial to that, and lateral surface of the internal surface of the mandible orbits the auriculotemporal nerve. So these muscle attachments are very important in elevation and depression of the mandible. The only elevator muscle is the lateral pterygoid muscle, remaining all depresses the mandible downwards, and the medial pterygoid and the lateral pterygoid helps in the lateral exclusive movements of the mandible. Coming to the biomechanics, how fracture happens, why fracture is happening? When there is a deep impact or a force blow directed towards the mandible, especially you think about mandible as a bow and archery, where the bow is pulled downwards to throw the arrow towards the target. So mandible is also similar to the hunting bow only. So when the force is onto the symphysis region, where it compresses the mandibular symphysis and dissipates the force on either side. So this part is strong enough so that it can dissipate the force. If the force is too much, this part will also break off. This dissipated force go to the weakest portion, that is the condyle, and it causes tension at both the condyle, leading to fracture of both the condyle along with the fracture of the symphysis. So in cases of parade ground fracture or Gottsman's fracture, when the blow is at the symphysis region, due to the fall from the height or due to the fall, inadvertent fall, it causes a deep impact or strong blow in the symphysis region, dissipating the force on either side to the weakest portion, causing a heavy tension at that weakest point, leading to fracture of the bilateral condyle. So in this picture you can see heavy force causing compression in the outer surface, leading to tension on the inner surface, fracture of the symphysis. Before it gets fractured, it dissipates force on the either side, leading to the fracture of the bilateral condylar head. So before we go to the management or studying about mandibular fracture, the very important thing we should know is the Champy's line of osteosynthesis. Champy, this guy, has given osteosynthesis line, nothing but the line along which the tension is dissipated, so that it acts as a buttress or it acts as a integrity line which holds the mandible. So if any fracture is seen, if a fracture is like this, we have to plate or join the mandible along this line to ensure the proper adaptation or anatomical reduction in the line of osteosynthesis where the tension is dissipated. We all know that in the area of tension there is bone deposition, and compression there is bone resorption. So to keeping that in mind, we have that the osteosynthesis line where the bone deposition happens, and the line of osteosynthesis between the inferior alveolar nerve canal and the alveolar process, that is just apical to tooth root, and anteriorly you can see two lines of osteosynthesis is there. So that's why we have to put two plates in the symphysis and parasymphysis region, because there acts the tension zone, compression zone rotates. It rotates anti-clockwise and clockwise direction, counterparting the each fragments. So that to prevent these three forces acting on the mandibular fragment, we have to put two plates to stabilize and reduce the fracture. So coming to etiology, what could be the etiology for mandibular fracture? The most common is RTA, that is road traffic accident, and followed by we have sports related, contact sports, boxing, hockey, football, basketball, and we have assaults, like where getting hit by other person, or fights. Those things will also result in mandibular fracture. And fall from height, if anyone falls from a tree or a building, this will also leads to facial fractures, especially the mandible. So now we are coming to the kinetic energy or the biomechanics of mandibular fracture. There are three types of kinetic energy, which is the kinetic energy 1, kinetic energy 2, and kinetic energy 3. So kinetic energy 3 is nothing but the combination of both 1 and 2. 1, where the person or patient is in stable position, that they are static, when the blow is in dynamic, that is in motion. For example, assault or getting hit by the other person comes under the kinetic energy imparted to the individual. The kinetic energy 2 is the object or where the force is given, that will be static and the patient will be in motion. For example, road traffic accident, fall from height, these comes under kinetic energy 2. The kinetic energy 3 is when both are in motion. For example, high speed motor vehicle accidents comes under kinetic energy 3. So when the impact is more, the fracture lines and the bones getting fragmented into pieces will also be more. So the risk of reducing it and treating it will also increase. So one is when the person is static and the object of injury is in motion, that is 1. 2 is when the person is in motion and the object is static, that is fall from height. 3 is when both the object and the person is in motion, that is high velocity road traffic accidents. So coming to classification of mandibular fracture, the most important one is given by Dingman and Natwig. Based upon the anatomy of the mandible, the fractures are classified. The most common fractured bone of mandible is condyle, which accounts for the 29.1%, followed by the angle, then the symphysis and parasymphysis region, then the body. The least fractured area is the coronoid process, because it is covered by the dense and the heavily fibered temporalis muscle. It is protected unless if the blow is very high or the impact is so much that it could fracture the coronoid process. So we have the alveolar process fracture, symphysis, parasymphysis, body, angle, and we have the ramus fracture and coronoid and condyle. Condyle being the most common type of mandibular fracture. And angle fractures is commonly seen in extraction of third molars and exerting more force, it will lead to the angle fracture. Then according to the direction of muscle pull, it defines the fracture's favorability. It can be horizontally favorable, unfavorable, vertically favorable and unfavorable. This horizontally favorable, unfavorable is noted from an OPG or a CT scan. In OPG, we have to see two-dimensionally, we have to see whether the fracture lines, if the fracture lines run from superiorly from the proximal side to the inferiorly to the distal side, or superiorly posterior and inferiorly anterior, this is favorable, because this buccal segment, this outer surface prevents the bone getting pulled by the muscles. Here the muscles acting are the medial pterygoid muscle, masseter muscle and the temporalis muscle in this upward direction, so that this anterior fragment of the fracture is getting hindered by the distal fragment of the fracture, that is the dentate fracture. It's preventing it from getting it pulled upwards. If the line is in the opposite direction, for example, superiorly anterior and posteriorly it is inferior like this, then there is no bone or no distal fragment to oppose its motion upwards. So this fragment is getting pulled upward and it is unfavorable, because the reducing such fractures is very difficult. And same goes for vertical fractures also, vertical favorability also, where we have to see from the occlusal view. In occlusal view, if the fracture line is from the posteriorly it is superior and anteriorly it is inferior like this, then it is unfavorable because this fragment will get pulled by the lateral pterygoid and medial pterygoid towards medial side, so making it unfavorable for the fracture reduction or difficult in other terms. And the favorability is when it is anteriorly it is superior and posteriorly it is inferior, it's going like this. This buccal fragment will hinder with the distal fragment, so that this movement of the fragment is prevented and there is no displacement of the fracture, which is easy to reduce and fix. Now coming to the other classification given by Kazanjians and Converse in the year 1974. Here he has classified the mandibular fracture into 3 classes. The class 1 is teeth are present on both the side of fracture line. For example, if this is the mandible and there is a tooth here and there is a tooth here and the fracture line is like this. If the teeth are present on both the side, like for example symphysis fracture is class 1 and teeth are present only on one side of the fracture line. Example, angle fracture, where the teeth are present only, if this is the third molar and the fracture line is like this and teeth is present only on this side, not on this side. This comes to class 2. Class 3 is seen in edentulous patient, when there is no teeth at all and the fracture mandible is noted, that comes in class 3. And in 1968, Rowe and Kelly also classified mandibular fracture. Type 1 is those not involving the basal bone, only in the alveolar part, only in the tooth bearing part. So this is your mandibular teeth, and for example this is your mandible. So fracture line is only limited to this portion, then it is the alveolar bone process only, it's fractured. This comes in class 1 or type 1. Type 2 is those involving the basal bone. It can be of only single fracture line, unilateral. It can be of parasymphysis, body, angle, condyle, double unilateral. Same side, when we have a parasymphysis and the body fracture, or when we have a body and angle fracture, very rare. And bilateral fracture, when we have left or right parasymphysis and left condyle, this comes in bilateral fracture. Right side parasymphysis and left side condyle, it's bilateral fracture. Multiple means comminuted fracture, multiple fracture lines. In case of AB velocity or I velocity RTA, you can see the multiple fractures. And another classification given by Vivek Shetty, it's based on the injury severity score, and this goes by Fawcett. What Fawcett stands for is F for fracture type, whether it is a incomplete, simple, comminuted or bone defect. Bone defect is seen in open fractures where the part of bone is avulsed. So if the defect size is more than 4 cm, then we have to go for grafting, bone grafts. If the defect size is more than 6 cm, then we have to go for free flaps. Most commonly used free flap is a free fibula. And we have location. Based upon the location, anatomic location, it is classified into symphysis, parasymphysis, angle, body, condyle, coronoid and all. And occlusion, whether occlusion is intact or it is deranged, or in case of no teeth, it is edentulous. Soft tissue involvement, whether it is closed fracture, open intraorally where there is a mucosal tear, open extraorally where is a deep laceration, both intraoral and extraoral opening is there, and soft tissue defect. When there is a high velocity RTA, there will be, along with the avulsion of the bone fragment, the soft tissue will also get avulsed. So that time there will be soft tissue defect. So we have to go for flaps to cover that area. Infection, whether infection is present or not, and displacement, as I said, vertical and horizontal favorability also we have to see. If it is mildly displaced, minimal or mild displacement, it is noted as mild. If it is a moderately displaced, it comes under moderate, and severely displaced, where the two fragments are heavily displaced, then it comes in the severe category. So this is Fawcett category to assess the mandibular injury severity score. So coming to clinical examination, how do you clinically examine the patient and how do you know there is a mandibular fracture? First, immediate assessment and general clinical examination, followed by the local examination. General clinical examination, we will go for the patient's airway, that is that ABCD, where we see airway and cervical spine, whether the patient is breathing or not. B stands for C for circulation, when any hemorrhage is there or not, and D is whether any disability is there or not, and E is exposure. To see the body from top to toe, head to toe, we have to analyze whether any other major injury is there or not, or bleeding is there or not. This is very important in any trauma. We have to assess this ABCDE to go for the further management. If the patient is stable and breathing and has no other injury, then we have to go for the local examination. In local examination, we will go for extraoral and intraoral examination, and based upon that we will categorize it what kind of fracture and what kind of bone is involved. We have to see how is the impact. If the blow is on the right side, there are more chances the left side condyle would have fractured. As I said, the force get dissipated and it causes tension at the weakest point, that is the condyle, and pushing it to fracture. And we have to see the mouth opening, whether it is limited or whether there is pain on occlusion, chewing. Those things we have to check. So local examination, loose or broken teeth, any broken dentures in case of edentulous patient, or a congealed blood where the blood clot is formed and it has been not cleaned properly. So those things in case of open fractures we have to see. And coming to extraoral examination, we have to check for the facial symmetry, whether any swelling is there or not, whether the face is symmetrical on either side or only left side is swelled up. So that means that there is a fracture or some injury on the left side. And we have to check for any abrasion, laceration. Abrasion is nothing but the exfoliation of the skin and the subdermis, okay, not going into the subcute. Once the subcute and the connective tissue is broken down, then it becomes a laceration. So that is a deep wound which requires suturing. And here we are giving digital pressure to see if you apply pressure in this area, if the impact is here and patient has bilateral condyle fracture, this portion will go inside and causing a displacement in this area, letting us know there is a fractured mandible. If on the bilateral sleeve, if you are applying force, if there is any parasymphysis body fracture, this mandible will just budge in. It will go like a sponge and you will hear the crackling sound, that is like crepitus. So there is a fracture in the mandible. And intraoral examination, we will see for deranged occlusion, any mucosal tear like this. And you can see there is a open bite on the right side and there is a premature contact on the left side. So this is because of the fracture in the symphysis region. This region is pulled upward, so there is making an early contact and there is no contact on the right side. And we will see for any ecchymosis. In case of mandibular fracture, the sublingual ecchymosis is called Coleman's sign, which is an important diagnostic hallmark sign for the mandibular fracture. And we have to see for any mobile teeth or any infection. These are all the things we should look into the intraoral examination. And coming to change in occlusion, see there is a left side, there is a parasymphysis fracture. So the fractured fragment is pulled up by the muscle, so it is making a premature contact with the maxillary teeth, thereby leading it to the open bite on the contralateral side, that is on the right side. So anterior open bite, when do we see anterior open bite? When there is a fractured bilateral angle fracture or a maxillary fracture, when get fractured and pushed down, it causing posterior gagging. Both the posterior teeth will be in contact, anterior segment will be open bite. And posterior bite in case of parasymphysis fracture, and unilateral open bite in, as we said, parasymphysis angle fracture, and the posterior cross bite we will see in symphysis fracture when the mandible is fractured and it opens like a book like this. That jaw gets widened out, so causing posterior cross bite. Retrognathic occlusion seen in bilateral condyle and bilateral angle fracture. So by both the side the fracture will be there, this mandible is pushed backwards. It appears as a retrognathic occlusion. And prognathic occlusion is also seen in case of bilateral angle fracture because of the muscle pull. So paresthesia, if any fracture line that traverses the mandibular canal leading to the injury to the inferior alveolar nerve, causing paresthesia in the lower lip region. And here you can see the area marked as paresthesia in this area because of the inferior alveolar nerve getting severed due to the mandibular fracture. And we have abnormal mandibular movements because the lateral exclusive movements, protrusion, retrusion, all will get hampered because there is a fracture, discontinuity in the bone. So it doesn't act in harmony with the muscles of mastication. So there will be restricted mouth opening and limited movements of the mandible is seen. Here you can see the posterior gagging and anterior open bite is seen. And here you can see a mucosal tear. So we can suspect a parasymphysis fracture in this area. And trismus or inability to close or open mouth because the fracture of the coronoid fragment goes and hit in the sigmoid notch. For example, this is your sigmoid notch and this is the condyle, this is the coronoid, and condyle will be here. So if the fracture in the coronoid process and getting pulled by the temporalis muscle, it will go and hit in the zygomatic arch. So initial 10 mm of rotation will happen, but anterior displacement, the remaining 20 to 30 mm of mouth opening of anterior translation movement will get hampered by the fractured coronoid process. So that's why there will be a limited mouth opening. So as I said, there will be a change in facial contour and mandibular arch form. You can see there is a swelling in the fractured side, and movement of the displacement of the mandible. You can see there, we can see the flattening on the right side, where the fracture is displaced, a fragment is displaced to the same side, ipsilateral side, because of the pull of the muscles. So if it is the fracture is on the left angle region, it will get pulled and the mandible is still pulled in the ipsilateral side. Coming to laceration, hematoma and ecchymosis, here you can say, as I said, this is the Coleman sign commonly seen in mandibular fracture, and mobility of the teeth, movement of the segmental mobility, where when the two fractured fragments move with each other, it crosses, when we rub the stones against each other, it will make some crack crack sound. So that is called crepitus. And palpation will give a step deformity. When there is a fracture line, can you see there is a bony fragment extending like this? So when you palpate the lower border, we will get a step deformity in that area. So then we will know that there is a fracture line. So to summarize, we have the signs and symptoms of mandibular fracture. Pain, first and foremost, is pain, especially while talking, swallowing. The second one is swelling or bruising. Then third one is bleeding from the periodontium, because there is a gingival tear. Alveolus, from the alveolus there will be bleeding. Sublingual hematoma is seen in case of mandibular fracture, Coleman sign. Drooling because inability to close the mouth. There is trismus, and altered bite, malocclusion is seen, and numbness of the lower lip, that is paresthesia of the lower lip, and trismus, loosened teeth, mobile teeth, and with medial displacement of the condyle, leading to the injury to the trigeminal nerve, can result in the ipsilateral facial numbness. That is very rare, but sometimes it can occur. The facial nerve may also damage if you all know that parotid tile is in the lateral border of the mandible, that is the outer surface. So if the blow is too much, this fractured fragment can go and traverses the parotid gland, which has the facial nerve main trunk inside, and as it comes out of the parotid gland, it gives the 5 branches. Okay, so this fractured fragment can go and poke the facial nerve inside the parotid gland. So coming to OPG, this is the basic imaging modality which is available in most of the places. So this gives you orthopentamogram, gives you the radiolucent line where you can see a discontinuity. So this is the should start from one condyle to the other condyle. So you start from the one condyle. So here you can see a irregularity, radiolucent line running from the sigmoid notch to the posterior border of the mandible. And we noted one discontinuity here, and as we traverses along the lower border of the mandible, it is intact. And again you can see a discontinuity here, a radiolucent line running from the canine to the lower border, and again we have to see the integrity of the bone till the opposite condyle, sigmoid notch and coronoid. So here you can see the 2 fracture lines are there, one is in the condylar area, other one is in the contralateral side parasymphysis region. So this helps us identify the mode of impact. So the impact would have been on the left side, this side. So when the hit is on this side, the force transmits along the body, symphysis, parasymphysis body, and goes and causes a tension in that condylar area, which is the weakest portion of the mandible, causing the condylar fracture at this area. So impact it on the left side and the force dissipates and causes fracture in the right side. But this is just a 2-dimension image. We don't know how much is the displacement antero-posteriorly, so we need to go for a 3-dimensional image. Same way, these are all absolute now, posterior-anterior mandibular view. Here also we can assess the fracture lines. CT is the gold standard, where you can see a 3D reconstructed image and also a 3-dimensional evaluation of the mandibular bone, so that we can assess the fracture in all 3 planes. The 3 planes are the coronal plane, this is the axial plane, and the sagittal plane. So in this axial plane we can see there is a break in the mandible and it is displaced. This portion which is fractured is pulled inwards and this portion is pulled outwards. So as you can see, it's a 3D reconstructed image. Fractured fragment is pulled inwards and this portion outward. So this helps in the management or planning for the plate fixation also. How much reduction we have to do and what are the structures involved. All those things we can be seen in the CT scan. So a 3-dimensional image. So this is a right body fracture, and here you can say left angle fracture. And coming to the management of the mandibular fracture, these are the 4 principles which is very common to all the fracture management, and is the soul of the fracture management. The first and foremost is reduction. We have to reduce the fracture into the anatomical portion as much as possible, and we have to fix it. Once you reduce it, for example, the mandible is fractured like this, and we have to reduce it. So we are reducing, but after reducing there should be something to hold this, right? So we can go for plate fixation, that is fixation. Then after fixation we have to immobilize it. So we will go for IMF, intermaxillary fixation, where both the dentitions are fixed. This immobilization, after the advent or after the plates, microplates and mini plates have come, immobilization is not necessary. Only when the occlusion is not corrected even after the fixation of plates, then we will go for immobilization. And early mobilization nothing but physiotherapy, because according to Wolff's law, whenever there is a tension generated by the muscles, so as I said earlier in the class, the mandible has so many numerous muscle attachments. So this muscle attachments puts tension on that bone, which leads to that bone deposition. So that's by leading to the bone healing. So if early mobilization is not proper or not started at the right time, it might cause delayed union or non-union, or if the early mobilization or fixation is not in a proper plane, it will cause to malunion also. So general principles includes the patient's general physical status, diagnosis and treatment, dental injuries, evaluation and treatment, re-establishment of occlusion, mandibular fractures to be treated first, because that forms the basis or framework to treat the other fractures like maxilla, orbit, nasal bone fracture, frontal bone fracture, zygomatico-maxillary complex fracture, all those things. And IMF time should vary accordingly, because in young patient the ideal IMF time, the duration of intermaxillary fixation is 2 to 3 weeks, because the healing is good. The bone heals faster in younger individuals. If you take an adult, the ideal time for intermaxillary fixation is 4 to 6 weeks, because this much time it will take for the callus formation, ossification and remodeling. So we have to go for 4 to 6 weeks in adult patient. If it is a geriatric patient whose bone healing is not as fast as the younger individuals, so we have to go for 6 to 8 weeks. In case of edentulous patient, we will have a special appliance called gunning splint, but we will cover it in the later part, and prophylactic antibiotics to prevent any infection and nutritional needs. As the mandible is fractured, the deglutition and mastication and chewing of the food is it is hampered like crazy. So for that patient, the nutrition is the key to recover from the injury. So to achieve a nutritional balance, we have to put the patient on solid diet, or we can either go for nasogastric tube in case of severely fractured jaw bones like a maxilla and mandible. So nutrition is the key for fracture healing. So as I said, airway, hemorrhage, soft tissue laceration if any is there, we have to immediately suture that area to prevent bleeding. So this laceration could also be an approach through which we can address the fracture and reduce and fix it. Support of broken fragments, like we can put a button bandage, or we can put an extraoral pin or a framework to support the broken fragments, and we can go for the management. Control of pain, like analgesics we can give, control of infection through antibiotics, and food and fluid for the nutritional balance. So coming to closed reduction. Closed reduction is where we don't see the fracture directly. Direct visioning of the fracture is not done. We are reducing it and putting the patient in intermaxillary fixation. Reduction and going for intermaxillary fixation without seeing the fracture directly is called closed reduction. Closed reduction is seen in patients those who are not fit for open reduction, or the fracture is airline fracture is there, or minimally displaced fracture is there, where the occlusion is intact. And open reduction is when there is a displacement of the fracture is more, severely displaced fractures, and the patient doesn't have any teeth, and patient's defect, the fracture defect is more. or the patient is like the patient cannot be put under IMF, intermaxillary fixation. The patient have a non-compliance patient can be taken for open reduction and fixation, where their general status is good and we can take them under open reduction and internal fixation. So indication grossly comminuted fracture, where opening the fractures would impair the blood supply to the fractured fragments. Multiple fragments will be there. If you strip the periosteum, mandible acquires blood supply from inferior alveolar artery and along with the periosteal supply. Now the bone is fractured into several fragments, the inferior alveolar artery would have been severed. So there is the blood supply to the mandible through inferior alveolar artery is doubtful. The other blood supply is from the periosteum. If we strip the periosteum, the bone fragments won't receive any blood supply. So it will go for resorption. So in case of grossly comminuted fracture, we will go for closed reduction, and fractures of the severely atrophic mandible, where as I said, once we elevate the periosteum, the blood supply goes off and it goes for resorption, causing it more difficult for us to treat and reduce and fix the fractures. Lack of soft tissue cover. When there is lack of soft tissue cover, opening it more would further worsen the situation. Then we will go for closed reduction, allowing it to heal by secondary intention. This can be contracted by using a flap to cover that soft tissue defect. Fractures in children, because there is a developing teeth bud will be there. For example, primary teeth is like this, and permanent teeth is developing underneath the primary teeth, and we can't put a plate here because these screws will hamper the developing tooth bud underneath the primary teeth. So this is contraindicated. So we will go for cap splint in case of children's. And infected fractures of lower jaw, where opening it would cause putting a foreign body like plates in the infected bone would also act as a nidus of infection and worsening the situation. So contraindication is poorly controlled seizures. When you put the patient in IMF, the seizure patient might aspirate and go for sudden death also. And compromised pulmonary function, where the patient can't have patent airway. In case of asthmatic patients, if you put them under IMF, there is a high risk of asphyxiation and death. And psychiatric and neurological problem, where the patient compliance is doubtful, we cannot go for closed reduction. And eating or GIT disorders, where the GERD or gastroesophageal reflux disorder, there the regurgitation of the food particles will cause, and there will be aspiration of the food particles leading to pneumonia and eventually death. So closed reduction and direct skeletal fixation involves the direct interdental wiring, indirect interdental wiring, and continuous or multiple loop wiring, arch bars, cap splints, and pin fixation. We are going to see one by one. So this is the direct interdental wiring, where the teeth are directly fixed against each others. So there is no bar or anything, just the wire is passed around the teeth, and it is fixed to the adjacent teeth by making loops. It involves Gilmer's interdental wiring. And indirect, we have eyelet. We will make loops of eyelets like this, and will pass around the tooth. So we'll make an eyelet like this, and we'll put between the two teeth. So the one loop goes around the adjacent tooth like this, and it comes out like this, and the other loop goes around the other tooth which is distal to this, and we'll put it get it out of this distal to the second premolar. And this arm we will pass into this through the eyelet or through the loop we have made, and we will secure it as shown in this figure, and we will secure it like this. So this loop will still be open. So the wire is passing this area and this opening through which we will achieve the intermaxillary fixation. So as shown in this figure. So we have placed the eyelet in the lower arch, we have placed the eyelet in the upper arch, and the loop is still open, and through which we will pass a wire and we will achieve the intermaxillary fixation. The continuous or multiple loop wiring, where we will make how the IV loop is made, we will make continuous loop, and we will put a wire through all the loop and we will fix it. If the wire is not there, we will put a bar through the loop and we will tighten this IV loop. So this bar will stabilize the mandible, acting like a framework. So coming to arch bar, where we put a bar with cleats in the upper arch and the lower arch, and we will pass the wire around the alveolar segment and taking support through the cleats, and we will secure it. These are the tacks. The wires are around the tooth and securing the arch bar in the upper quadrant and the lower quadrant, and these cleats are used to achieve the intermaxillary fixation, where the teeth are put in occlusion, in the proper occlusion, and it is secured. This is cap splints done in a pediatric patient, where the occlusal surface of the teeth are released or relieved and base plate is made in proper occlusion. So what we will do is we will make the cast, we will take an impression, we will make a cast, and we will fracture the cast in the exact fracture location, and we will stick it, or we will reduce it manually, and we will fabricate a plate after the reduction. This plate will be put into the patient's mouth, and it is secured through circummandibular wiring. So we will go from the lower border, take a stainless steel wire and go along the fabricated plate and go through the lingual side and comes out of the lower border, and we will secure the wire. This is kept for how many days? Kept for 2 to 3 weeks in pediatric patient. So pin fixation, we will put an external framework and we will put multiple pins to stabilize the fracture. This is done in comminuted fracture, where these holds all the fragments together and helps in the reduction and fixation. That's why it's used in the older days. Now there are we use customized plate fabrication, where we use CAD/CAM 3D surgical planning, where we'll customize the plates for the fractures and we will plate it. So the advantages of closed reduction: it's inexpensive, easily available, convenient, and it is a short procedure, and it's stable. No greater operator skill is required, because there is no anatomical structure we are going to disturb, or no intraoperative bleeding, or no intraoperative damage to the vital structures, and it allows for callus formation, and it yields by the ossification of the callus formed. The disadvantage is not a rigid fixation, and the stability after the reduction would be not as good as the plate fixation, and patient those who are not compliant with intermaxillary fixation, it will go for a failure. And difficult in nutrition, because there is no mouth opening and the nutrition is mainly on liquid diet, so it will affect the patient nutrition. So there will be patient will be deficient of so many nutrients, so that we have to cover it with the supplements. Complete oral hygiene is impossible, because the arch bar fixed will have food debris will be there. Patient has to maintain the oral hygiene properly. If not, the food particle gets stuck in that arch bar, will cause infection. So coming to open reduction, where we open the area and see the fracture directly, and we will reduce and fix it. So here we will indication is displaced or unfavorable fracture, like unfavorable vertical, horizontally unfavorable fractures can go for open reduction, internal fixation. Multiple fractures of the facial bone have to go for open reduction, and midface fracture and displaced bilateral condylar fracture, at least we should address one condyle and we have to fix it. In condylar fracture, if not treated early, and there will be hemorrhosis leading to TMJ ankylosis in young individual. So the condylar fracture should be addressed, and early mobilization, it's the key in treating the condylar fracture in pediatrics. Early mobilization. The fractures of the edentulous mandible with severe displacement of the fracture fragments, we have to treat it with load bearing. So whatever the mini plates we have seen, it's load sharing, because load sharing is important for the fracture healing, because it acts by the Wolff's law, where the tension is there. The load from the occlusion will helps in the bone deposition and leading it to heal faster. But in edentulous, there is no teeth, there is no such thing as load sharing in that area, and thereby we have to go for load bearing. So there is no teeth, so we have to put a heavy plates. Okay, open reduction and internal fixation is contraindicated in case of patient not fit for a general anesthetic procedure. Severe comminution is present, and creation of stable units with rigid fixation is not possible. Bone at the fracture site is diffusely involved with the infection. Patients refuse a more complex treatment approach, and thereby patient consent is, when we are not able to get the patient consent, we can go for closed reduction. Most of the people are scared of surgeries, so getting a patient consent is first and foremost in treating any fractures. Advantages: early return to normal jaw function. There is no need for intermaxillary fixation. After the plate fixation, patient can start with the normal chewing, starting with soft diet, and normal nutrition is retrieved. A normal oral hygiene can be maintained. Avoidance of airway problem. Once we fix that, it is stable and there is no tongue fallback or no other aspiration and life-threatening condition in open reduction internal fixation, and can get absolute stability. That's the major advantage of the open reduction internal fixation, and promotes primary bone healing. where we saw in closed reduction secondary bone healing. The bone contact is not, there is a minimal gap in the bony fragments, where in rigid fixation there is no gap in the bone, so it heals primarily. There is no callus formation, directly the bone will heal. This aversion canal from this fragment and the aversion canal from this fragment slowly forms a bridge and the fracture heals. In case of semi-rigid, there is a small gap of like 1 mm or 0.5 to 1 mm gap will be there. This is then it heals by the second bone healing, where the callus formation will be there. Disadvantages: significant operating room time, prolonged general anesthesia, expensive ward, where cost wise it is more expensive than the closed reduction. Then other injury to the neurovascular bundle in case of inferior alveolar nerve, mental nerve, when we are reflecting the flap, that time there are more injuries to the inadvertent injuries to the adjacent neuromuscular structures. Need more operator skill, meticulous technique in case of open reduction and internal fixation. So the treatment by open reduction and dental skeletal fixation involves transosseous wiring, where we just put wires to reduce the fracture and fix it, or we can go for plating, intramedullary pinning, titanium mesh, circumferential stamps, bone clamps and bone screws like lac screws can be used in mandibular fractures. So lac screw, which is most commonly used in symphysis and parasymphysis area. So the screw enters from one cortex, it is a bicortical like the buccal cortex and lingual cortex. From one side it enters to the buccal cortex, and the opposite side it goes and engages into the lingual cortex, and thereby it is a rigid fixation. Okay. Then the methods of open reduction can be intraoral through the mucosa, or extraoral through the existing laceration, or extraoral incision we can enter the fracture area. Factors used to establish the location of incision includes fracture location. For angle fracture, we won't put an incision in the submental region. We will put an incision in the submandibular region posteriorly. And for a condyle fracture, we won't put a submandibular incision, we will put a retromandibular incision just posterior to the mandible and 1 centimeter below the earlobe. In this area, we will put a incision of 3 to 4 centimeter parallel to the posterior border of the mandible to enter this area, condylar fracture, and along the skin lines to get a cosmetic result out of it, aesthetically pleasing incision we have to go for. And nerve position, the nerve is there, then we can't put an incision on there, especially in case of mental nerve intraoral incision. So the extraoral approaches are submandibular, given by Riston in the year 1934. This is the lower border of the mandible, 2 centimeter below the lower border of the mandible, an incision is placed. Why 2 centimeter, why not 1 centimeter if you ask? The marginal mandibular nerve goes along the lower border, or 1 centimeter from the lower border, 1 centimeter 2 centimeter from the lower border. So incision should be placed above 2 centimeter, like 2 centimeter from the lower border only we should place incision, so that there is no injury to the marginal mandibular nerve. So along the lines of the creases, so that we can mask the incision line, so the scarring won't be that visible. And this is in case of comminuted fracture or multiple fracture, we can go for a visor incision from one angle region to the other angle region. So we can open the flap and we can see the entire mandible. We can approach this in case of comminuted fracture, where we need a recon plate for load bearing action. So coming to intraoral, it's a vestibular approach or a degloving incision. Mostly in case of body symphysis and parasymphysis fractures, we use this. So an incision is placed from 5 mm or almost 0.5 centimeter from the attached gingiva, because we need this cuff, tissue cuff, to suture it back. So we put an incision in the mucosa, then we will get a mentalis muscle. It is dissected 90 degree to the bone. So the first incision is on the mucosa, the second incision is towards the bone, detaching the muscle, and we will strip the muscle off and to reach the fracture segment. So in this case, between the two premolar, mental foramen will be there. So while giving the incision, we have to be very careful. First we have to give the mucosal incision, identify the nerve, then we have to skeletonize the nerve, separating it from the mucosal attachment, and we have to strip the muscles from the bone to get into the fracture line. If any injury to the mental nerve occurs, there is the loss of sensation, and to the lip region will act. So in case of old patient, this is called bucket handle fracture, bilateral body fracture in older patient. So the bone height is very small, and it can be treated either by gunning splint, closed method, or in open method we have to put a recon plate, heavy plate from throughout the mandible in the lower border to support it, because there is load sharing activities, only load bearing, because there is no dentition to share the force. So the resistance of the bone to trauma is further reduced by changes in the structure of the bone associated with the process of aging. For example, in younger individual, there is both the blood supplies are intact, where the bone heals faster. In older individual, due to the atrophy, there is severe bone resorption, the inferior alveolar canal get occluded in most of the cases, becoming a more sclerosed bone. So if that inferior alveolar artery is getting compromised, it derives blood supply from the periosteum. Even if we strip the periosteum, there is no blood supply, leading it for resorption. So fractures are much less frequently compound into the mouth than when the teeth are present, and the absence of teeth means that the precise reduction is not necessary. If the teeth are there, we have to keep it in occlusion to reduce it, but when there is no teeth, there is no hard and fast rule to reduce it anatomically. As near as possible to the anatomic reduction is mandated. So in cases of management of edentulous mandibular patient, we'll go for direct osteosynthesis, we'll go for recon plate, and we'll go for wiring, where we'll do circumferential wiring like circummandibular wiring, or we can go for gunning splint. This is the gunning splint. The one advantage of gunning splint is there is an opening in the anterior so that the patient can have sufficient nutrition through this. And, if there is existing dentures, we can knock off the front tooth, both the maxillary and mandibular, and creating an opening and putting a hole in the denture, giving a outlet or inlet for the wires to pass to immobilize the both maxilla and mandible, allowing it to heal for 6 to 8 weeks in the geriatric patient. Minimum of 6 weeks is mandated. So coming to pediatric patient, the second most commonest fractures with the incidence, and condyle is the commonest site. As I said, if condyle is involved in pediatric patient, we should reduce it and start the physiotherapy at the earliest to prevent the TMJ ankylosis. Developing tooth bed, so the plating is quite risky in this cases, which will affect the developing tooth bed, leading it to the damage to the permanent tooth bed. Then there will be no permanent teeth, and leading it to cyst formation or infection, or even it might cause us further complications. And most commonly in children, because they will be playing in school grounds and falling, or in case of getting skid and falling in the stairs, all these things are seen in kids. So the best treatment, close reduction, would be cap splint, where we will release the occlusal surface of the teeth and we will put a base plate fabrication, and it is adapted with the help of circummandibular wiring. Or we can go for bioresorbable plates, where we will put the plates and screws and it gets resorbed in the span of 6 to 8 weeks, giving us a good 2 months for the bone to heal. So this is the cap splint. It is fabricated. First we will make a cast, fracture the cast in the exact area where it is fractured, and reduce the cast and make the fabrication. After that, place it in the patient's mouth and secure it with the circumferential wiring or circummandibular wiring, and later on after 3 weeks, can you see the fracture is reduced. So what are the care we should take? It can be immediate, then late post-operative care. Immediately we have to maintain the patient, control the pain, prevent the infection, and oral hygiene maintenance and proper nutrition. Late post-operative care can be of looking for any malocclusion, any non-union or malunion, adjustment of the occlusion. All these things comes in the late post-operative care. And complication arising during the primary treatment can be infection or any injury to the teeth. Late complications can be, as I said, malunion, means the bone is not fixed in the proper anatomical frame, or delayed union means if we are fixing the 3 months is the ideal bone healing time, 3 to 6 months. If more than 6 months the bone is not healed, it comes under delayed union. Non-union, even after 3 to 4 months the bone, that you can see still a gap between the two bony fragments, comes in non-union. The limitation of mouth opening, where because of trismus and the fracture is not healed properly, and scars. It can be of keloid or hypertrophic scars. And infection, if infection is there, there is more chances the plate exposure will be there. That time we have to remove the plate and irrigate that area nicely, and we have to revise the edges, and we have to go for suturing. Then malocclusion, even after healing there is deranged occlusion, because the bone heals not in the proper anatomic position. Delayed healing, even after 6 months the bone is not healed, and the gap is still noted. Non-union means the fracture is not only united but will not unite on its own. So non-union cases, we have to reassess the case and we have to redo the procedures again to fix it in proper anatomic position and achieving the proper occlusion. It can be of infection, due to infection, inadequate immobilization. When putting the patient on closed reduction, patient is not compliant and start moving the jaws at the earlier time, then it will go for a delayed union or non-union. Unsatisfactory apposition of the bone ends. When you reduce the bony fragment, there shouldn't be any gap. If there is a gap and you are reducing and these two fragments are mobile, then definitely there will be a non-union or delayed union. And as I said, inadequate blood supply leading to bone resorption, and patient those who have osteoporosis or nutritional deficiency or vitamin D deficiency, there will be limited bone deposition leading to delayed healing or non-union. Scars, when we go for extraoral approaches, there are more chances of scar formation, hypertrophic or keloid formation, injury to the tooth roots. In case of intermaxillary fixation, I forgot to tell you, there is intermaxillary screws, IMF screws are there. So where we will screw it, instead of putting a wires or a arch bar, we'll screw in 3 areas and we will pass on a wire into it to achieve the intermaxillary fixation. If these screws are pushed or placed into the tooth root or the apex, it will cause for tooth damage. Then the patient might require root canal treatment for the teeth to save the tooth. And while fixing the fracture, then if the tooth is mobile and if the tooth is in line of fracture or if tooth has any periapical lesion, these teeth should be removed. If not, then it will cause infection and there will be plate failure. Then the non-union or delayed union will occur in these cases. Limited mouth opening, when the early mobilization is not followed properly, there will be restricted mouth opening, which we have to open it manually, or we have to take the patient to see whether it is a malaligned or malunion of the bone fragments are noted or not. So coming to the recent advances, the last topic of this today's class, endoscopic approach, where we will put minimal nick incision and we will use the transoral approach. Through the oral cavity, we will put the endoscopic tube and we will visualize and operate it through the small area with a small incision only. We can proceed for the closed reduction or open reduction through this endoscopic approach. And this advantages are no visible facial scars and minimal risk to the facial nerve injury. So it can be done extraorally or intraorally, and this endoscopes helps us to visualize the area in a much better way and reduce the fractures in a more feasible way possible. So to summarize, mandibular fracture, we should know the mandibular bone properly to know its anatomy so that we can reduce it in the proper anatomical position, and we should always get the occlusion back. So occlusion is the key to reduce the mandibular fracture. Then the principles of fractures or fracture management are reduction, fixation, immobilization and early mobilization. And we have the classifications given by Dingman and Natwig, Kazanjian's classification, Rowe and Kelly, and Vivek Shetty given the Fawcett classification, which assesses the mandibular injury severity score. And we have the imaging techniques. We have OPG, CT scan is the gold standard one, and we are coming to clinical assessment. How do you assess it? Extraorally, intraorally, local examination, and facial symmetry, mouth opening and deviation of the jaw. Then we'll go to intraoral, any ecchymosis, that the Coleman sign, sublingual hematoma, and any alveolar, gingival alveolar gaping or step deformity or a deranged occlusion, anterior open bite seen in the bilateral angle fracture, or unilateral open bite seen in the contralateral parasymphysis fracture, and bilateral condyle and angle fracture leads to the protruded chin appearance. And all those things we have discussed. And management comes to closed reduction and open reduction. Closed reduction will put the patient, reduce the fracture. Where we don't see the fracture directly, we'll reduce the fracture and put it under intermaxillary fixation, and for 4 weeks in adult and 6 weeks in geriatric patient and 2 to 3 weeks in pediatric patients. And open reduction, we have transosseous wiring, plate fixation, we have mini plate, recon plate, and we have screws, lag screw, which comes under rigid fixation. And we have approaches, intraoral vestibular approach, extraoral submandibular, retromandibular approaches for visor approach for treating the mandibular fractures. And finally, we came across the recent advances through endoscopic treatment to treat the mandibular fracture. So these are the references. Thank you students for listening to my classes.